So, John, I think we're all here. Yeah.
Okay, all right. So, good afternoon, everybody, and a very, very warm welcome to this second webinar in our Prevention Community of Practice series of webinars. Very nice to have you all here. It looks like, if I'm seeing the right button here, it looks like we've got 132 people just at the moment, and they keep on coming in. So, very nice to see you all. Thanks for taking your time to be with us this afternoon. Just very briefly, this is a webinar that's part of a series of webinars, which in turn is part of a community of practice that we are building now at ECDC for prevention of infectious diseases, with a focus on social and behavioral sciences. And we have two fantastic speakers with us this afternoon, who Stefan will introduce in a moment. And they're going to be talking about how social and behavioral sciences can be incorporated into decision-making processes and into policy. So very, very warm welcome to you. And I wish you a very nice and stimulating afternoon with us. So back to you, Stefan. Stefan is going to be moderating this afternoon. He's a policy advisor with the European Health Management Association. So over to you, Stefan, and thank you so much.
Thank you very much, John, and welcome everybody. Before we start with the content and the actual presentation, I have a very few housekeeping notes to make. First of all, as you have seen, this meeting is being recorded. It will be uploaded afterwards on the ECDC Virtual Academy, EVA, and to the open social platform once it is launched. John will provide a bit more information on that at the end of this webinar. Importantly, questions are really encouraged. So we will first have the two presentations, but afterwards there is a Q&A session and there is a panel discussion. So please, if you have any thoughts or questions you would like to ask, use the chat for this. We will be closely monitoring the chat and ask these questions for you. And if you see a question popping up that you really like, just give it a like, and so we know what the priorities are for the Q&A and the panel discussion. Then I would like to invite our first speaker of today. Kim Lavoie is a professor and Canada Research Chair in Behavioral Medicine at the University of Quebec at Montreal. She's the lead investigator of the International Eye Care Study, which assesses population attitudes and adherence to infectious disease prevention measures, including vaccination. And today she will share her research and experiences on how to effectively use behavioral science to inform policymaking and what must be done to improve behaviorally informed policymaking. Kim, the floor is yours.
Wonderful, thank you. Just confirm that you can see my slides. Hello,
yes.
Hello.
Yes.
Okay, there's a little delay there. No problem. Well, listen, thank you so much for the invitation. It's my absolute pleasure to be here today to talk about how we can leverage more behavioral science and insights from the behavioral sciences to inform public health interventions, particularly those that aim to target both individual to population level behavior change. These are my disclosures, but there's nothing pertinent to this presentation. So a little bit of background just to kind of get us all set. As we know, the pandemic, which was declared by the WHO on March 11th, 2020, has arguably been the world's most challenging crisis since the Second World War. And from the very beginning, it was clear that the key to slowing the spread of the virus and successfully transitioning out of the pandemic as quickly as possible was, and arguably still is, strategic adherence to prevention behaviors like mask wearing and optimal uptake of vaccination. And because mitigating the effects of the pandemic really required mobilizing the global community to adopt a series of behavioral changes that were not very familiar to us, that placed a significant psychosocial burden on people, many of us in the behavioral sciences thought, wow, I think they might need us a little bit to get the population on board with adopting these behaviors while we're waiting for vaccines to be developed. And even after the availability of vaccines, that's another health behavior that many of us know, of course, in the context of a pandemic, are going to be crucially important to mitigating the spread of the virus and help mitigate their effects. So I'm going to try to address with you in the next 20 minutes or so three key questions. What is, first of all, needed to change behavior? And when I speak about changing behavior, I'm going to be speaking about individual all the way through to population behavior. Of course, populations are made up of groups of individuals. So how do you mobilize a community and a globe to really get on board with behavioral adoption of behaviors that are new and can be actually quite intrusive? The second question is, did public health experts around the world optimally leverage the behavioral sciences, theory-driven intervention models and frameworks that have existed for years to inform their policy designs and implementation? And the third question is, what now needs to be put in place, both now and in the future, to improve the design, implementation, and effectiveness of interventions targeting behaviors at the population level? So I have one slide on Behavior Change 101. In fact, there are probably 80 to 90 theories of behavior change. And if I whittle them all down, there's essentially 4 boxes you need to tick to change any behavior in anyone, anywhere. So this would apply to people. This applies to children. If you have teenagers at home that won't clean your room, anything at all, these are really the 4 things that are absolutely crucial. The first is knowledge. So first of all, people need to be aware of the problem and acknowledge that there is a behavior to change. So I gave an example here of the problem here in the pandemic being an airborne virus and the fact that wearing a mask could help prevent the spread. So this is quite similar to addressing alcoholism. The alcoholic who doesn't acknowledge his drinking problem is not going to join AA. So knowledge is key, but of course insufficient on its own. Motivation. People need to believe that engaging in the behavior is important and will lead to personally relevant or beneficial outcomes. And sometimes those personally relevant outcomes are benefits to their community or their family or others. But bottom line is motivation is not motivation to get out of the pandemic. It's motivation to engage in the behavior, and that is usually tied to perceptions of the behavior itself being important. The third criteria is confidence. People need to believe that they can have the necessary skills and resources to engage in the behavior. So they might want to engage in it. They might be motivated. They might know it's important. But if they don't have the tools and resources, well, that's going to undermine confidence, and people tend not to act in those situations. And the last critical factor is opportunity. So people need to have access to the structures and systems required to engage in the behavior. So early in the pandemic, there was some uncertainty. Do we really need to be wearing masks? But one of the problems worldwide is we didn't have a stockpile of masks that we could make available to the population quickly. So this led to a lot of uncertainty on the part of policymakers. Should we recommend masks? Should we not? But of course, this is impossible to adopt if we don't have the stockpile of masks that we can make available to the public. So knowledge, motivation, confidence in the context of having an opportunity to engage in the behavior are critical for behavioral changes to happen. And this is particularly true in the context of health. Now, some of you might be familiar with the COMBI model, the Capability, Motivation, Opportunity model, which is put forth by Susan Meeke and colleagues at UCL. And just to kind of map on this model to the 4 factors that I previously described, capability really speaks to, do I know what to do and can I do it? Motivation, how will I and others benefit? And opportunity is it possible to do? And if we take back now the example of masks wearings, capability might translate as, do I know masks are protective? Can I find a mask that is comfortable and wearable? Motivation, do I believe masks will help reduce virus transmission, help keep me and others safe, help keep us working? And opportunity might translate into, are masks available, accessible, and affordable? Now, problems with some traditional public health interventions, and again, I'm going to stick with the mask wearing example, with regards to public awareness campaigns. When you just really focus your interventions on raising awareness, imparting knowledge, attacking that first factor I described, is that in the end of the day, most people with regards to health behaviors, including pandemic related, most people know what to do. Most people throughout the pandemic knew what behaviors they should and shouldn't adopt, but they didn't always do what they know. So we refer to this in behavioral science as the knowledge behavior gap. I'm sure if I were to poll all the participants today and ask you, how many of you know that you should be exercising probably about 150 minutes a week? probably all of you would raise your hand, but if I were then to ask you how many are actually doing it, I'm not so sure I'd get as many hands raised, and mine would be one of them that wouldn't be raised. All of that to say is this knowledge behavior gap is very, very common. And so, that's one of the major limitations of just raising awareness, is that this intervention assumes that the problem, or the most important problem, is knowledge. And if only people knew what to do, that would automatically lead to behavior change. And of course, we know this isn't true. And that's because most public awareness campaigns don't address motivation, the why should I do this, or confidence, which is the how. Making masks available, affordable, and wearable, just addressing opportunity, obviously also doesn't address the why, beliefs about importance and benefits. And one thing we often saw during the pandemic, I know I did here in Canada, is focusing on the negative consequences of not engaging the behavior, scare campaigns. And this is very different from focusing on the positive consequences of engaging in the behavior. So the problem with scare campaigns is that these campaigns typically ignore years of behavioral science research showing that eliciting strong negative emotions in people is not only ineffective, and if it is effective, it's only temporary, but this may actually be counterproductive, particularly in the long term, because it tends to elicit defensiveness and build resistance. And that's because even if you succeed in scaring someone, emotions turn on a dime. We've all experienced the full range of human emotions: happy, sad, scared. And guess what? Those fear responses don't last. So if you're relying on fear or negative emotions as your primary motivator for change, and those motivators change so quickly, well, then you've lost your motivation to engage in the behavior. So we typically do not recommend any messages that really resort to inciting fear in people. And as one example, this is Francis, and Francis is a real patient who got COVID early in the pandemic, and he was used in an ad campaign here in Quebec, Canada, back in September 2020 to encourage Quebecers, particularly younger Quebecers, to wear masks and distance and so on. And as you can see, Francis has a stoma, so he got COVID quite early in the pandemic and was quite severely affected. And this campaign completely backfired here in Quebec. And in fact, the conspiracy theorists didn't trust that this was actually a real patient. They believed that the government was trying to manipulate Quebecers and scaring them into adopting the behavioral measures. You saw things in the media like "you're a liar," just like the government. And this was actually directed towards Francis, who showed a great deal of courage in sharing his story to try to encourage and persuade Quebecers to adopt the measures. And so this campaign completely backfired. I feel so sorry for this man, who's actually a real patient. And so this just is a concrete example in real life of a way in which these kinds of campaigns can go terribly wrong. So what can we do? It's not all doom and gloom. How can we improve the design, implementation, and effectiveness of interventions targeting behavior? Some of you may be aware of the behavior change wheel. I'm not going to go into this in too much detail, but just to let you know that there's this fantastic framework that can be used by policymakers in public health, and it really describes interrelated behavioral science frameworks and principles that can be used to inform the design of your interventions. There are theoretical bases for linking barriers and facilitators to intervention strategies, and it's really meant to guide decision-making in a step-by-step fashion. And just to guide you through the wheel, you'll see the COMBI model here in the middle, and these are the things that we need to target in order to change behavior. The things in red are what we might call the interventions. So we can restructure the environment, put hand sanitizers at the place, in front of stores and schools. And by restructuring the environment, we might increase adoption of the behavior. And at the outside ring, we have the policy category. So these are policy measures that can be put in place that can encourage people to adopt different behaviors. So, we saw regulations about mask wearing if you wanted to enter certain businesses, service provision, environmental and social planning. These are all different things that we can do to encourage people at the population level to adopt a series of health behaviors. So this is just to make you aware of this model, and this is something that we use a lot in the behavioral sciences to inform population health interventions. There's also another framework called the APPEASE framework, which is a set of criteria used to make contextual decisions about the content and delivery of a public health intervention. And it really just helps guide decision-making along 6 different variables. So you want to make sure that whatever you design is acceptable to your target population, practical in that it can be delivered as intended. You can scale it up, that it's obviously effective, and it can deliver the desired outcomes for which it was designed. It's affordable for whoever's paying for it. You want to make sure that that you don't see any unwanted spillover effects or negative consequences, and you want to make sure that whatever you put in place is equitable. Now, other examples of using behavioral insights for designing public health interventions. Interventions should be informed by theories of behavior change. Targets should be clear and measurable. Interventions should be co-developed with the target population. Protect each other, and this is who we are messages were shown to be particularly effective throughout the pandemic. And you want to make sure that whatever you communicate to the public, that you provide regular feedback on how those interventions and how people's efforts are doing. So this is something we saw a lot in Canada for sure. A lot of telling the population what to do, a lot of information giving with regards to this is the pandemic situation in terms of cases and hospitalization rates. But they didn't do so well at showing the public graphs about after we've implemented these policies, how case rates and hospitalizations are going down. So this goes a long way to positively reinforcing the efforts of the population and can be done in a simple press conference. Public health messages now. I'm going to give you a quick list of shoulds and should nots, and we'll start with the shoulds. It seems obvious, but you want to be clear and consistent. You want to avoid presenting contradictions in policies. One thing we saw here in Canada as well, and I know elsewhere, is that jurisdictions that were very close together. So Quebec is a province and Ontario is a province, and they neighbor each other, and they're about the similar size and similar demographics, and yet you saw very different, much stricter policies in Quebec. We had lockdowns and curfews that we didn't see in Ontario. So that left Quebecers scratching their heads. Well, wait a minute, we have the same case rates and the same population roughly in the two provinces. Why do they get to go out at night and see their friends and we don't? So this obviously undermines people's willingness to engage in the policies, and also results in less credibility in the part of policymakers. You obviously want your messages to be delivered by credible, trusted sources. And again, as I mentioned before, you want to emphasize the positive outcomes associated with engaging in the behavior rather than the negative consequences or punishments that we could experience by not engaging. A quick list of should nots. Try to avoid being authoritarian. You should, you need to, because these tend to undermine people's needs for autonomy and their motivation to change. You want to avoid using shaming and blaming. This tends to build resistance in people. And as I mentioned before, using messages that seek to arouse fear or disgust in people. So what can behavioral and social scientists bring to the public health table? This was a great paper by Van Bavel et al. In Nature Human Behavior in 2020. We can provide insights on how to manage threat perception, how to increase trust and compliance, how to present leaders in a positive vein so that this increases the perception of their credibility in providing health messages. Individual and collective interest, how do we get people to improve their individual and collective decision making, the science of communication. So there's a lot of work that we've been doing around that. How do we leverage factors that from the social context? How do we leverage social norms and how people tend to adopt more behaviors if they perceive them to be normative? And then how do we manage stress and coping, which was obviously a huge factor throughout the pandemic, and I think it still is. So what is needed to improve translation moving forward? I'm going to do a shameless plug that I think we need more research. And yes, I'm a researcher, a clinician researcher, but my dream is actually see much more collaboration between public health and behavioral scientists. And just a little data point, despite the central role of behaviors in reducing, COVID-19 transmission, only 18 of the 26 or so hundred registered intervention trials in the world have been in the behavioral and social sciences. That represents less than 1%. So is this, I think this is in part due to the fact that funding envelopes tended to prioritize biomedical research rather than behavioral and social science. And I think we need to do more here. So I'm going to end with a quick snapshot of something called the iCare study. Now, the iCare study is something that came about really quickly in March 2020. It's a study that I co-lead with many investigators around the world. It's called the International COVID-19 Related Attitudes, Concerns, and Responses Study, and it had 3 essential questions. What are the determinants of COVID-related policy adherence? What policies are associated with better and worse adherence, and which ones were more effective at reducing infection and transmission? And what are the impacts of both COVID-19 and its prevention policies? Now, the goal of this study was to provide rapid data-driven recommendations to local and international governments. And the goal was obviously to optimize policy responses. And it really got off the ground in, not joking, 3 weeks. And what we did to get it off the ground, because we had no funding, I basically rolled over in bed with, I was there with my husband and we worked together. We've worked in prevention of chronic disease for over 25 years now. And I said, Simon, the world is going to need to change their behavior on a massive scale. Vaccines aren't going to be available for a while. We have to put something together, and we need to contact our International Behavioral Trials Network to do it. And that's what we did. So the IBTN is something that we launched about 10 years ago, and it currently includes over 1,300 members in the behavioral and social sciences around the world. We reached out to our network, and we managed to mobilize hundreds of researchers to get on board with helping us put this study in the field. So iCare is an international, cross-sectional, multi-wave observational behavioral study that's still ongoing. It includes a series of online surveys, which are linked to case policy stringency and Google mobility data. It's a study that's currently ongoing with over 170,000 participants to date around the world. It includes a global convenience sample of nearly 70,000, representative samples in target countries of over 90,000, and an embedded Canadian longitudinal study of just over 10,000. And the map here depicts where we have our representative samples that are more repeated measures. It was truly and is truly an international collaboration. At its peak, we had over 200 collaborators from 42 countries, and the survey was available in 36 languages. And what we did, as I mentioned, the goal was really to provide rapid data that could inform policy for governments. And I was fortunate to be invited to join the Government of Canada's expert panel as a behavioral science expert, but we worked with a host of other governments, both provincial and international, including the Government of Australia and Ireland. And that's really a really nice model for how I think behavioral science can work with government to inform policy in real time. As you can see from this slide, we've been really, really busy, but just to say we're open for business, so to speak. We have analysts ready to go, a ton of data from around the world, and I know that this is an international webinar, and please reach out if you'd like to join or you're interested in accessing the data. We'd absolutely love to have you, and I'm excited for the discussion period in a minute or at the end of Hannah's talk, where I could tell you some more. And I'm just going to end with a snapshot of some insights from the iCare study that were used to inform policy in Canada and elsewhere. I'm just going to show you the slides quickly because I want to move on to Hannah's talk, and we can come back to the slides again if you have any questions. So this is just a quick summary of all the publications and where they emanated from around the world. As I said, we've been very busy, and we, thanks to the funding we received primarily here in Canada, we were able to hire analysts, which allow us to exploit the data much quicker. A few high-level things that we saw that I think are interesting. One is we looked very closely at vaccine hesitancy, both in Canada and around the world, and we were able to kind of provide a portrait of those who tended to be more hesitant. We saw this in more women, people who are younger, visible minorities with less education. Saw this more in parents, which is something I think we should talk about later. And those with a positive history of getting the flu vaccine tended to be less hesitant. We looked at what people are concerned about in terms of the pandemic, financial, social, health concerns, and perceived importance of prevention measures, and how this mapped onto hesitancy. We saw that people with high health concerns tended to be less hesitant. People with personal financial concerns were more hesitant. People who perceived prevention measures to be important were obviously less hesitant. And these are just what a select snapshot of some of our infographics that we used for dissemination and knowledge transfer. This is changes in COVID-19 adherence to behaviors in Canada early in the pandemic. This is just a sample of what motivates people to be vaccinated, both among the vaccinated and non-vaccinated. So vaccinated were most motivated by wanting to protect others, doing their part. Non-vaccinated, most motivated by low number of side effects and effectiveness. Here's some data on effectiveness of vaccines as it relates and vaccine waning that we did in collaboration with COVID End and the Spore Evidence Alliance here in Canada. Here's, and the one on the right is sort of what's the situation with long COVID. So we've really adapted the survey over time to ask questions that are more related to issues at hand in the moment. So just to conclude, have public health experts around the world optimally leverage the behavioral sciences to inform policy? I personally don't think so. We've heard a lot about behavioral sciences, it's about nudging people and sort of, simple little interventions. Nudges is one of the behavioral science behavior change techniques that we can implement, but it's not very sophisticated and it tends not to get people to engage in behavior change over time. What is needed to change behavior? It's more than just education and opportunity. We need to address motivation and skills. And what needs to be put in place? I think greater collaboration of behavioral sciences and public health, that is my dream. Greater participation of behavioral scientists on policy advisory boards and more funding for behavioral research. I want to take a shout out to some of my collaborators in the eye care study and my lab at the Montreal Behavioral Medicine Center here in Canada. And I turn it over now to Hannah for her presentation. Thank you so much.
Thank you very much, Kim. And I already see the discussion moving in the chat, but feel free to continue ask questions that Kim will answer after Hannah's talk. But we now move on to the second presentation of today. Hannah Nohlen is a social psychologist and a behavioral scientist working at the Competence Center on Behavioral Insights at the European Commission's Joint Research Center. And she works on the application of behavioral science to support evidence-based decision-making. In this capacity, Hannah has conducted behavioral research on a range of topics for which behavioral science is relevant, including public health, but also misinformation and disaster preparedness. Today, Hannah will share findings of an EU case study on embedding behavioral insights into public health policy making. Hannah, over to you.
Great, thank you so much. Can you see my, I'm just shared the wrong slides, so let me just stop this and reshare.
No worries.
Let me see, I think this should be the right one. Yes, can you see my slides?
Yes, we can see it.
Perfect. Okay, then we can start. So first of all, let me thank you for inviting me to give this webinar, and thanks to Kim for this really interesting presentation. And I will actually get back to some of the things you said regarding how public health policymaking can benefit from behavioral science. But I want to start off giving you a bit of background on our team and the organization itself. So I work at the Joint Research Center of the European Commission, which is the European Commission's Science and Knowledge Service that carries out independent research to provide independent scientific advice and support to European Union policies. So within the JRC, the Behaviour Insights team is part of the EU Policy Lab, which includes 3 teams. It's the team on foresight, design for policy, and the Behaviour Insights team. Now, if you want to know more about any of these 3 teams, I've linked them here below, and I have a QR code at the end of the presentation as well, that will bring you directly to our website. Now, this is the team working specifically on behavior insights. It's the Competence Center on Behavior Insights. And our goal at the CCBI is to bridge between behavioral science and policy, so to bring a more nuanced and evidence-based understanding of human behavior to the policy-making process. by taking into account what drives human behavior and considering factors such as motivation, social influences, habits, and contextual effects. We conduct behavioral research ourselves, but we also translate behavioral science findings for EU policy. We raise awareness and build capacity on behavioral insights to inform EU policymaking by giving, for example, trainings to policymakers. Now, what's interesting is that we work horizontally, which means that we apply behavior science across various policy areas, and we don't only focus on one specific area. So as Stefan already said, I, for example, have worked on health-related topics, but also on crisis and emergency preparedness and on misinformation, for example. Now, what I want to talk about today is two things. First, I want to present a case study that we conducted in 4 member states on challenges and good practices of embedding behavior insights into public health policy making. And then secondly, I hope I find the time to shortly present a paper that we're working on unlocking the full potential of behavior insights for policy. And we're also in that echoing something that Kim said, which is that behavior science is more than just nudges. So the BI4EU, the Behavior Insights for Public Health in the EU project, is a relatively small scale study in which we conducted interviews with experts working in or with public health institutes in 4 member states. And we were interested to learn about their best practices and perceived barriers to institutionalizing the application of behavioral and social science in public health decision-making. And with institutionalization of BI units or activities, we're referring to the process of allocating sustained funding, formally including BI expertise in an organizational structure and assembling a team of staff members that are engaged specifically in BI activities, all within a framework of an official mandate. We conducted this with a group of experts in behavioral sciences coming together from different organizations, with colleagues from the ECDC, the Finnish Institute for Health and Welfare, the Dutch National Institute for Public Health and the Environment, and Mariana Baggio, who's now at Eurofund, was a colleague at mine at the JRC. And the research was carried out, and the interviews were conducted and analyzed by 2 independent researchers from the University of the Netherlands and the University of Utrecht, Danny de Vries and Marijn Stok. So let me start off, and I don't think it's necessary in this community, but just so that we're all on the same page, let's start off with the definition of behavior insights, or actually applied behavioral science. So applied behavioral science investigates the cognitive, social and environmental drivers and barriers affecting behavior within a specific context, for example, health-related behaviors. So it's really the application of findings from behavioral science to analyze and address real-world issues. And one of the goals in behavioral science is to identify factors that influence our behavior, to understand how the behavior of those around us or the way in which we perceive information influences our decisions. Now, insights that are created in behavioral science can be relevant for policy when a policy concerns people's behavior, which it often does. For example, in consumer protection, going away from public health, how certain design choices online influence consumer behavior, for example, but of course also in public health when we're talking about communicating about protective measures, for example. So the idea that behavioral evidence is crucial for advancing the goal of good health for all has been gaining traction in recent years and decades. And this became especially clear during the COVID-19 pandemic. So we know that public health threats and emergencies take place in the social, cultural, and behavioral contexts. For example, cultural beliefs and practices influenced how different communities responded to public health guidelines. So mask wearing and social distances were more readily accepted in some cultures, but faced resistance in others. And public health efforts are more likely to succeed if they consider these contexts. Now, during the pandemic, behavior science researchers published a lot of interesting papers aiming to provide guidance to decision makers on findings that would support the COVID-19 pandemic response. And here just really just some examples. And the relevance of building BI expertise for public health was also underlined by the adoption of the WHO Regional Office for Europe resolution for the use of behavioral and cultural insight, and the first global resolution on behavioral sciences. And similarly, this community of practice for prevention of communicable diseases also contributes to this effort to mainstream BI in public health policy making. However, there are large differences between member states in the extent to which they've prioritized working with BI and the extent to which behavioral insights are applied in public health policy and practice. So for this project, we wanted to explore good practices in establishing and maintaining effective national BI infrastructures and activities. We wanted to identify the barriers that people experience and the facilitators of implementing behavioral insights within the administrative system of the countries that we were looking at, and explore ways of providing support to retain this BI expertise. So ultimately, we also wanted to facilitate reflections on how to bring behavioral and social insights to the attention of decision makers. I want to mention here that there's these 3 related studies, and there may be more, that collectively draw a similar picture of the experience of implementing BI research findings in the different countries. And our study contributes to this wealth of finding. So we conducted this study. We conducted interviews with experts working in the area of behavior insights for public health in 4 EU member states: Spain, Portugal, Italy, and Slovenia. And we had 11 key informants, and we conducted these semi-structured interviews. So this allowed the interviewer to follow up on topics that emerged during the interview. For more details on the methodology and also all of the findings, because I will only be able to highlight some of them, I'm referring to you to the scientific report that's going to come out soon. So let's turn to the results. So it was a really rich data set, and as I said, I'm just going to be able to focus on some of the findings here. What I would like to highlight is that this is really what experts reported during the interviews, so their view and opinions, and then these findings reflect the observations of the interview participants in the selected countries. So what we found was that in general, the key informants in our case studies felt that decision makers' support still for behavior science or behavior insights for public health policy making still depends on individual people and is not yet systematically embedded. And we broadly categorized the challenges that were experienced to the implementation of social and behavioral research findings into awareness, organization and capacity challenges, budget constraints, and then the consequences for the impact. So in general, looking at awareness, behavior scientists are not common in the field of public health, which has traditionally been an area of expertise for people coming from disciplines such as medicine, nursing, epidemiology, etc. And the hiring practices are also often aimed at these other academic backgrounds. So the relevance of BI is not necessarily obvious and present in some public health institutes. Moving to the organizational and capacity constraints, given the small number of BI professionals in the organizations, much of the work is actually carried out externally through project work by BI units that are located within academic institutions, something that's called a hub and spoke model. Another barrier that was mentioned was that bureaucratic procedures can often slow down people's ability to respond to requests in a timely manner. Interviewed experts also highlighted differences in organization. So in decentralized countries with regional authorities, there may be BI teams at regional level that, for example, also collaborate with other BI teams at regional levels. But in other administrations, collaboration on BI activities may occur on a particular topic across units, which may be more feasible than having a central BI unit that covers a range of topics. So due to some of these constraints, the impact that we could have sort of sometimes depends on who knows who. So it really depends on the individual, on the one hand, on the BI expert and their ability to sort of be an advocate for behavior insights and for the behavioral science approach, but also the benevolence of well-placed individuals. Looking at the good practices, participants were asked about key factors that they believe can contribute to the success of institutionalizing BI expertise in public health policymaking. And what we found was, what we consistently found was that they were highlighting collaboration between academic and public health institute as a good practice to solve, also to solve long-term capacity issues, and having individuals who are knowledgeable of BI in the policy area, who can serve as interlocutors or communication partners and can facilitate integration, so inform of relevant policy questions that are on the table. Advocacy by people who are visible in the organization or visible in the policy world to motivate political support for the behavioral science approach were also seen as very useful. And of course, having or working toward more continuity in staffing was seen as a key factor, because continuity in retaining expertise was sometimes hindered by short-term contracts or project-based contracts, which meant that people moved on to different things and the expertise was lost. The role of international organizations, they were seen as connectors in the sense that they can develop communities of practice, such as this one, provide training possibilities and create networks of professionals for the exchange of experiences. So some learnings from this study. So this study has helped us understand and formulate different needs across some member states. But we've also learned that there's no one size fits all, but there are nuanced requirements and thus different ways of integrating behavioral science into public health policies. For example, a group of BI experts that collaborates in a network across regions or departments instead of creating a central BI unit that works across areas. It's also shown some similarities, that the challenges that were faced were quite similar across situations, and common ways forward included improving collaboration and working towards sustained advocacy, which may also be facilitated by international networks. Now, important to note is that this is really a qualitative study based on a relatively small sample size and cannot claim to be generalizable to other settings in the EU or beyond the immediate context of the participants. But I would also be interested in hearing your experiences from your countries, whether they match or are similar or maybe very different from what we've seen here. So I'm not sure. I think I have a few more minutes, so I'm gonna dive into this this topic, which is because the topic of more integration of BI in policymaking is fitting, I want to take some time to talk about a current paper that we're working on, which looks at how we can benefit from the full potential of behavior insights for policymaking in general. So we're moving away from just the focus on public health, but actually, you know, these are struggles that we don't only have in public health, but in policymaking in general. So recently there has been a discussion on the use of BI in policymaking, and here are some reference papers in which different researchers reflected on what is necessary for applied behavioral science to sort of fulfill its potential. What some of these say is that there is a danger of using behavior insights as a sort of plug-in policy tool to complement existing policies through, for example, behavior interventions, rather than using the full potential of BI to design policies. So some researchers criticized the focus on individual interventions, suggesting that this puts the burden on the individual instead of working towards more systemic change. And we're currently working on a paper in which we address how we think BI can best be used for policy and better integrated in policymaking. And for the sake of time, I'm going to focus on just two aspects. I want to provide an overview of what BI can do for policymaking, and I've got some examples as well, and just tell you what we are doing at the CCBI to work toward what we see as a more ideal situation in which BI is integrated early in the policy cycle. So there is a critical role of behavior insights in enhancing policymaking, and a necessity for both changes in individual behavior and changes in our social, economic, and political system to address future challenges in many policy areas. And this figure here, I don't know if you can see my mouse actually, but my cursor, the figure to the left illustrates in which policy-making contexts BI can be involved, expanding from the individual to the system of policies. Basically, at the moment, we're often limited to involvement through behavior interventions and single policies, including the implementation of policies. But there is scope for more integrated involvement and potentially impact. So moving from targeting individual behaviors through interventions to guiding the choice and the development of policies, improving alignment of several policies toward a common objective under policy mixes, and identifying conflicts and synergies between policies across different areas and their effect on the behavior of individual stakeholders. Now, I will give you some examples from our work at the EU Policy Lab, just to illustrate the ways in which BI can support policymaking on different levels of abstraction. So this is, as I said, not necessarily in the area of public health. So behavior interventions have been used to help in the implementation of a regulation to make existing policy more effective, for example. This happened as an example when environmental labels were mandated in the eco-design regulation for smartphones, aimed at empowering consumers to make more environmentally friendly choices. Now, in this case, behavior scientists were called in after the decision to implement labels in order to design the labels, making sure that they're more effective, transparent, and acceptable. And for the eco-design regulation, that meant, the findings showed that graded environmental labels were more effective than binary labels, which simply indicate if an option is good or bad. So this way of involving BI in policymaking is the most commonly understood and used. So BI develops an intervention as a follow-up to an already existing regulation or to support the communication of traditional policies. But in this case, BI is rather a plug-in, as behavior scientists have no input or say on whether a label is the appropriate action or not. Another way in which BI can be integrated more effectively would be in informing the development of policy, informing the policy choices, or even guiding the policy design. So from our own work, we have an example on better protecting consumer rights by considering human biases and limitations. That's the 2011 EU Consumer Rights Directive. So before this directive, I'm not sure, maybe you remember, pre-checking boxes online were allowed. So if you bought a flight ticket online, the box, for example, to buy an additional insurance was often pre-checked. And colleagues did a behavioral analysis, and that revealed that these practices exploited consumer inattention and their tendency to follow the default. And this analysis resulted in the suggestion of bans as the best response to these practices. So really a behavioral analysis led to a traditional policy instrument, a regulation or ban being implemented. For the sake of time, I think I'm going to skip this one. So what we're really working toward is the idea that BI can be used to identify the aspects in the system that are behavioral and need to be addressed all together through different domains and with different actors, looking at connections and interactions between policies to change the system in which behavior manifests. And this is where BI's impact would be most efficient, though examples of this are rare. And if you have any, I'd be very happy to hear about them. What we are, so a greater integration of BI in the policy system requires BI to be integrated early in the policy cycle. And as seen with the BI for EU project, this is really difficult to achieve. So these are the steps that we are taking at the CCBI, or that we're trying to do to achieve better integration just within sort of our organization. So looking at creating awareness, we're trying to establish a behavioral culture through communication in events, workshops, conferences, seminars, etc. We've also started a CCBI webinar series that's accessible for policymakers, but also for interested practitioners and researchers, which is monthly. We have a newsletter and thematic workshops that are for sort of bring together policymakers and researchers. We also try to build capacity on BI among policymakers by providing trainings, for example, and workshops in which policymakers and researchers can come together. We have developed tools to quickly react to requests. Often a problem is to respond and provide results in a timely manner. So having an infrastructure in which we can relatively quickly conduct online studies and experiments helps us to be able to respond timely. And we also try to identify what's on the policy agenda ahead of time and build relationships to collaborate closely with policymakers. So if you want to find out more also on the things that I've mentioned, here I have some links. We have the webinars that are monthly, our newsletter that can be that you can subscribe to. And for now, I would like to thank you for your attention, and I look forward to the discussion.
Thank you very much, Hannah. Kim, I also invite you to share your camera so we can move towards the Q&A and the discussion. I already saw you answering some questions in the chat, Kim. Thank you very much on this. And well, a lot of topics emerged, but one of the common, an important theme that was mentioned is how to actually improve the collaboration between policymakers and researchers. So, for example, Sylvia Healy asked, having sound research to support policy is one thing, but do you have any suggestions regarding how to successfully reach the policymakers? I think from the perspective of a scientist. So maybe, Hannah, could you start sharing your ideas on this?
Yeah, I think this is a crucial question, really, right? Because it's often difficult to sort of bridge between the two worlds. The scientists don't know how to communicate their findings or how to bring them to the attention of the policymakers, and the policymaker does not necessarily have the time and the background maybe to understand what the scientist is trying to say. So I think there's different ways to go about this. So one thing, of course, is how do you disseminate the research, right? I think Kim had some very good, interesting examples of how to communicate the results. She had really accessible infographics, for example, that I thought would, really show, like, in a short, like, one page, what the results of the study were and how to use them. But I think also it's very important to have to sort of, we have these BI trainings for policymakers in order to raise awareness and sort of let policymakers know that, we are here and this is what we're working on, and also so that they know where to go and whom to contact in order to know more about a particular policy field. So I think there's also something to say about building capacity on the one hand and sort of trying to bring the two worlds a bit together.
I might have
Thanks.
something, Stefan, to add.
Yeah,
that's
go ahead.
A little bit different, and this is kind of speaking from experience. So I've been working basically in prevention of chronic disease. So, how do we get people to stop smoking and exercise? So things that are highly relevant to public health. And, I've been doing this a long time. It was only when we started doing the eye care study, and what we did is because our objective was how do we mobilize the population? So one other thing I'm going to add to what Hannah said, which I absolutely agree, is what we decided to do, because we didn't have a lot of direct ties, let's say, with public health or a lot of pre-existing collaborations, is we put out a lot of press releases. And what happened was very quickly, we got a whole lot of media invitations to speak on the news, okay, in Canada, in Quebec, in Canada. And let me tell you, once you're on the news and on like national news, the policymakers are all listening. And what we did is we dug into our behavioral science expertise and said, okay, we're not just talking to the population, we're talking to them. So in the same way as you change individuals and population behaviors, well, the same criteria applies to policymakers and influencing them. So in other words, you know, what we tried to do when we did our interviews, and they had to be very, very strategic because they don't give you a lot of time on TV, is we try to identify the problem that the government was also identifying for the public, and we tried to show them how we might have some constructive and feasible solutions that they could potentially consider and implement. And we actually said, we're open, give us a call. Okay, like we were, and we did hundreds and hundreds of interviews throughout the pandemic, and I'm convinced that that is what got me invited to our National Advisory Board. Is you go out there and you make use of that that's the most, I think, highest impact knowledge translation time is that 4 minutes on a national interview, or that, 10 minutes on a, radio call. So you want to be very strategic, and I want to encourage scientists to get comfortable presenting in that way. And a lot of us I'm okay with it actually, but a lot of scientists are not comfortable talking to the media. But it's so powerful if you can harness some behavioral science, throw that into your communication, and it can really go a long way. So I just wanted to add that that's another way to get, I think, their attention. And like Hannah said, you have to knowledge translate for policymakers. So you have to kind of get out of your scientist bubble and jargon and all of that stuff and say, I need to make this brief, I need to get to the point, I need to make this actionable. So you need to summarize, thousands of data points in a page.
Wow.
And yeah, so that's the challenge, but I think that's one additional way we can get it done.
Yeah, very interesting. And you already during your talk you said that they suddenly realized they actually might need you to help counter the pandemic, and but it was actually through the media that you got their attention.
I'm sure it is. Yeah.
Yeah. Okay. One point that might be related to this was made by John Kinsman, and it relates to maybe some confusion on the terms that we often use to present behavioral research. So John asks if you could reflect on the term BI, for example, as opposed to BCI, which I think is behavior change intervention, or just social and behavioral sciences. Why would you consider these to be essentially the same thing? And if so, is this confusing to people who may want to utilize these kind of our collective expertise?
I'll say one thing quickly, and then I'd love to hear Hannah on this as well. So the terms we use are important, and I acknowledge that there's a lot of confusion out there, and I would take this on us. I think that's from the people in the behavioral scientists to really get this straight and make sure that it's clear. From my position, I think there's two things that are important to understand. There are theories and frameworks that help us understand what contributes to behavior happening in the first place. And then there are different theories and frameworks that help us change behavior. And they're not always the same. Okay, so behavioral determinants and behavior change determinants or interventions are not necessarily the same. And so we can, I think, do a better job separating. If you want to understand why behavior happens, these are your theories and frameworks. If you want to change behavior, these are your theories and frameworks. So the behavior change wheel is a behavior change theories and frameworks model. Whereas behavioral determinants might be the health beliefs model, is some that many may be familiar with. So I'll stop there, but Hannah, what do you think?
Yeah, so So the term BI or BCI, I think, is BCI is behavioral cultural insights. That's the term that was basically coined by the WHO. And what it does is it acknowledges that there's cultural differences next to just the behavioral factors in the mental behavior science research that influence behavior, for example. Actually, the term that I personally, sometimes I find the term behavior insights or BCI, just the term insights, not the best term in the sense that basically everybody can have an insight, but we're talking about applied behavior science. So this is really, this is an education that, takes a lot of years, and it's not just somebody who suddenly had an insight on how we can influence behavior or how we can understand behavior. That's what it really is about. It's about understanding behavior, but it's a scientific approach to understand how behavior comes about, what are factors that influence behavior.
I completely agree with Hannah. And in fact, within the behavioral sciences, I don't know if you would agree, Hannah, but we don't use behavioral insights. That's not a term that we came up with. And I think from the policymaker perspective, and let me know what you think, Hannah, I think it kind of dumbs it down. I think it kind of doesn't do it justice. And I agree, it's much more fairly represented as applied behavioral science to solving some of the world's greatest problems. And I think one of the not next problems, but one other problem we're tackling is climate change, because behavior is important there too. So I think I agree the term behavioral insights kind of makes it sound a lot softer than it actually is. So
yeah, and we're maybe in a position where we're a bit like, I'm not sure if we're stuck with it, but it's sort of the term that is now widely used, and so everybody uses the term behavior insights, even though I don't have any data on this, but I can imagine that a lot of people would actually say applied behavior science is what we're doing.
Yeah. Okay. So we might need to apply this knowledge to rebrand our perspective or domain. And a nice future challenge. There was also a question from Christian Mulder, specifically to Kim, and it relates to the scare campaigns. So he appreciates the recommendation to discourage that, but on the other hand, it seems that many anti-tobacco campaigns, for example, are almost inherently designed around such strategies. Could you please elaborate a bit on why they do not seem to work?
Yeah, well, one of the red flags I want to raise is whenever the tobacco industry doesn't lobby strongly against your public health campaigns, it's because they know something that you don't know. Okay. And I would bet my career on the fact that they are completely and totally aware of the utter inefficacy of scare campaigns for tobacco cessation or not taking up tobacco. And they would be completely correct. So all those gruesome images you see on a cigarette package, they know because they've done the research and they've read the behavioral science data showing that it's completely ineffective for dissuading certainly young people against taking up cigarette smoking. Why does it persist? Why do we keep seeing these kinds of campaigns? So that first red flags is really important. I think we keep seeing it because I think that people think behavior change is somewhat intuitive. I think a lot of policymakers think it's somewhat intuitive. It's just common sense. If people knew all the horrible things that could happen, people would change. But people aren't rational. And we're not always irrational either. And so I think part of the problem is this perception that it's easy. And if people only knew what was logical and rational, change would come. And that's simply not the case. Human behavior is far more complex than that, but we're not without our methods for very effective ways of changing behavior, both in the short and the long term. But it's mind-boggling to me because, punishments are infinitely less effective than rewards or positive reinforcement. And this is back to the 50s. This is like, when the 70 years ago, this is like learning and psychology 101. This is like chapter 1 of how to, behavior change. So again, I can only say from my experience, I think it's a reflection of the fact that public health, I don't believe in my experience, and certainly correct me if I'm wrong, don't get any real hard training in how to change human behavior on a population scale. And so I think they revert to some of these common sense approaches that in fact there's a lot of excellent and consistent evidence that it's not effective, which is a real shame. But the trick there is that if the tobacco industry isn't lobbying against your campaign, they know it's not going to work.
Yeah, thank you. Thank you very much for this clear answer. Another group of questions relate to the importance of trust as a concept in these interventions. So, for example, during press conferences to show the results of policies within the EU, there was an increasing problem of credibility of how the media was viewed and how credible it was. How important is this topic from a behavioral science perspective, and how to deal with that for example in a pandemic like we had? Hannah, maybe start with you.
So I think trust is very important. It's something that's I'm not sure how quickly it can be developed, to be honest. But I think identifying trusted sources to present information is crucial, and that's also what's been shown in some of the studies. I think, Kim, you showed the paper by J. Van Bevel on the that mentioned trust as well, and in a follow-up study on that. That I had on one of my slides, they actually looked at which of these 19 suggestions that were done in this paper had large effect size or a big impact. And one of the 3 with the most impact wasn't indeed using trusted sources or credible sources to present your suggestion. But Kim, I don't know, maybe you have more to add.
Yeah, I mean, well, I just wanted to actually compliment something I said before. With a colleague of mine, Ariane Bélanger-Gravel, at the Université of Laval here in Quebec, we actually did a study to kind of ask public health, what's your relationship with behavioral sciences? What do you think? And so on. And I put the link to the paper in the chat. And it really underscored this, I guess, provided some, more data on the reasons why we tend to see this disconnect between, applied behavioral science and its use by public health. And some of the main things that came out was they just didn't identify with it being part of their mandate to really master or behavioral sciences theories and models. Greater reliance on experiential produced knowledge rather than empirical, okay, is what they tended to do. The belief that theories and frameworks from the behavioral sciences are too complicated and take too much time to implement. And so it's not, very dismissive of that. And the belief that, as Hannah pointed out, really importantly, that behavioral sciences, there's this perception, and I've experienced this firsthand in public health, that behavioral science puts all the responsibility on the individual for addressing, bigger social problems. And behavioral scientists are kind of giving industry and governments a free pass by, trying to empower individuals to make their own changes in the face of, policies that should be changed. And from us on the inside, we're like, that's absurd. Of course, we would never, ever, let industry and government off the hook. But at the same time, we still want to help people to control what they can, and at the same time use behavioral science to lobby policymakers and governments to change policies. So all of that to say is, I think there's this resistance, actually, active resistance within some branches of public health to actually work more with behavioral scientists because of this perception, which I think is a complete misperception and myth. So anyway, I don't know, Hannah, if that's your experience as well, but it's certainly my international experience.
So I think, I mean, that really relates to the paper that we're currently writing that I also shortly mentioned. I think it's a misperception that indeed behavioral science can only talk about or puts the blame on the individual we have to target the individual, and thus we don't have to take care of any policy changes, systemic changes, etc. And that's what I tried to sort of show in some of the in the later slides in my presentation, is that behavioral science has a lot to say about how we can, analyzing the system, what are the different policies, how do they interact to influence individual behavior, and how can we sort of try and align these policies and think about policy design and not only about the implementation of policies that have been thought of independent of any sort of knowledge and for lack of a better word, insights on behavior, individual behavior. Yeah.
And Stefan, keep in mind that, if public health doesn't have a tradition of, training or, fostering mastery of sort of applied behavioral science, we're basically standing here in front of them saying there's this whole wealth of knowledge that you might want to, learn a bit more about in order to do your jobs more effectively. That might be perceived as like, well, wait a minute, I've been doing my job effectively all this time. Who are you to come in and tell me that we're not? And at the end of the day, we're actually standing in front of them saying, well, maybe there's some things you need to change. And public health folks are people too. And human beings, Behavioral Science 101, are resistant to change, because change comes with a lot of uncertainty, comes with maybe, change is hard. It's not easy to exercise 150 minutes a week. If change was easy, we wouldn't be sitting here right now, right? So all of that to say is, I think we need to approach our collaboration objectives with public health with the same sensitivity and perhaps sophistication as we would any other behavior change, and understand that it's not just for us to swoop in and say, here's all the great stuff you guys need to now learn. What I would like to see more, and this is what I try to promote, is greater collaboration. I don't think they need to master everything that, a behavioral scientist would bring to the table. But we would just, I think, love to work together on the problems that are common to us all, and that we're all working hard to fix and change and address, and that's what I'd like to see. When I work with physicians, I don't come to the table learning medicine, but I come with complementary expertise that help the physicians achieve their end goals, for example, with regards to health.
Yeah, thank you very much. So it's to increase trust or to deal with trust. There's also this big challenge to increase trust between the different complementary perspectives that we need to address. Then there are also a few questions that more relate to the methodology of developing behavior change policy or behavior informed policies and analyzing them. And one of them relates to the fact that sometimes evaluating these interventions can be really expensive. For example, if you want to have large scale RCTs to assess the effectiveness of a certain intervention, but often there's also the problem with limited budgets in countries, and that may be a problem to really thoroughly evaluate these type of interventions. What would your recommendation be to policymakers in this regard? Kim, maybe start.
I'll jump in. Yeah, I'll jump in. I think I might say, I often say things that are controversial, but that's more fun, I guess. So regarding, the comment about, behavioral studies are expensive. You know what's expensive? A drug trial. Do you know what the success rate of getting a molecule to market? It takes about 15 years. and arguably billions of dollars. And this is well documented. And that's not the kind of money we're talking about in terms of increasing the funding envelopes for behavioral and social sciences. I know that our local funding agency, which is equivalent to NIH or NHS in the UK, the Canadian Institutes of Health here in Canada, their overall funding envelope for health research, roughly 85% is in biomedical sciences, and they leave 15% to cover the other three pillars of, population health and epidemiology, social sciences, and I think something else. Anyway, clinical studies. Bottom line is, we need to increase the funding envelopes for this work. And I'm tired of having to apologize for what it costs to do excellent science. And I'd like to think that the pandemic sort of raised the flag to say, wait a minute, all the illness and suffering and hardship we may have been able to prevent if we were ready, if we had all the best evidence mobilized and ready to go. And a lot of it was already there. It just didn't make it to the eyes and ears of the people that were responsible for managing the pandemic. And so that's sort of my controversial comment 101, is that I'm not going to apologize for what it costs to do excellent science. And I'm pretty sure we wouldn't want the vaccine developers and the people manufacturing our drugs to cut corners and do cheap science in the interests of being expeditious. I think science costs what it costs, and we shouldn't apologize for that because we're not in the biomedical sciences. Hannah, what do you think?
Yeah, I mean, I think it's a question that basically every science has, right? Everybody's always like, oh, we have too little, or there is limited. I mean, we all, there is a limited funding pot, let's put it that way. And everybody wants more of what's in the pot. if you want to see it that way. So all the sciences, I think, are struggling with the same issues, right? And yeah, I'm not sure how everybody is solving it in all of the other sciences. What I see is that collaborations can be very useful, right? Pooling resources. I think that's also what we see in other sciences. But yeah, I mean, I also don't have the answers, except that we're all struggling. Everybody's always struggling with limited budgets and funding.
And one thing, Stefan, there was a comment about, other designs. One thing I think that we have an opportunity in the behavioral sciences, there's a whole host of clinical designs that aren't RCTs, that are actually often better designs to ask and answer many of the questions that we have. Quasi-experimental, smart adaptive trials. There's so many. I want to point people's attention to something called the ORBIT model or the MRC complex interventions models. These provide frameworks for development and testing, early phase to late testing, translational research in behavioral interventions. And so you can often glean a lot of information doing much smaller, even non-randomized trials. And particularly in the context of the pandemic, you could have, and we did provide some of that information through our study. So all of that to say is there's a lot of things I think we can do and a lot of novel designs that aren't that expensive that we can leverage to provide quick information in the context of a pandemic and other things.
Well, thank you very much. I see that we are already almost at the end of this webinar. So first of all, I would like to thank you both, Hannah and Kim, for the brilliant presentations and the excellent discussion that we had. And I would like to give John the floor to have some final comments.
Thank you very much, Stefan, and thank you so much, Kim and Hannah, for such an interesting discussion. And as Stefan said, some really brilliant presentations and ideas and everything. And I just, when we were talking there, I thought one of the things that really struck me as a sort of take home is we're dealing with, we collectively, we've got 155 people right now. We've been up to about 220. We are social and behavioral scientists, and we have a particular expertise, and we're struggling with trying to get our expertise, our scientific findings onto the plate, as it were, of the people making the decisions. Why are we struggling? We're the people who should know about behaviors. We are exactly the right people. We have a unique ability, in theory, to be able to get ourselves onto that table because we're behavioral and social scientists. So we need to think, as you were saying, Kim, about how we can how we can change our messaging according to the audience, and the audience being those people, whether we're going to be 4 minutes, 2 minutes, soundbite on the TV or get onto the radio, whatever it may be. We need to think carefully about how we can use our own science to provide our findings to the right people at the right time. So to me, that's quite an interesting sort of insight, for want of a better word, that we've had from this discussion. Lots of interesting things, lots of good food for thought. So a couple of other things I just want to say before we leave. I want to thank everybody, all of the, we were up to 220 people, as I said, for actually spending nearly an hour and a half with us. And I really, really hope it's been worth your while. Some fantastically interesting points coming in the chat, some really good engagement, good questions, good comments. Thank you for sharing. Thank you for asking. Just to clarify again, this webinar is part of a series. We had the first one just before the summer, and on health literacy. This one is now, and we have another one coming up next month, and it's going to be about the end of next month, and it's going to be about trust in public health. And I think a lot of the issues that we've been talking about today will also be, taken up again and discussed and taken further in that. So do please join us. Charlotte and the colleagues from the community of practice will be notifying you about that via email and by social media. Just also to say, this community of practice, we are in the, I think you can say, the nascent phase of it. We've just finished a pilot with about 50 people on our platform, trying to get some of the issues, some of the little glitches as we move forward. And I think we've come up with a good few things that we can fix to make it better. We're now working on that. And the actual launch of our community of practice will be the full launch will be in November the 20th, in fact, at the ESCIDA conference. So as of then, all of you will be welcome. And I should also say that it is for EU people, EU EEA people, would be very welcome to express interest in joining. This community of practice is for people who work in public health authorities. It's for people who work in universities and in research institutions. It's for people working in civil society and in community-based organizations. So it's a pretty big, diverse collection of people who are going to be involved. And I think as such, great strength in numbers. And this also slightly responds to one of the points that was raised in the chat there. Is like, what's ECDC doing for training on social and behavioral sciences? Well, bingo. Thank you for that question, because that's exactly what we're trying to address through the creation of this community of practice, through these webinars, through e-learnings, through online trainings, and through the opportunity to network and share experiences and good practices with each other. So that's what's going to happen. And so for those of you who are interested, Charlotte, my colleague, will be posting a link for a call for expression of interest, and that's going to come up in the chat. So if you'd like to see, if you'd like to express your interest, if you'd like to join the community of practice, stand by and that link will be coming. So that's it, I think, for now. Thanks again to Kim. Thanks again to Hannah. Thanks to Stefan for managing everything so nicely. And here comes the expression of interest for the community of practice from Delia. Thank you for that. So click on there if you're interested, express your interest, and stand by for November the 20th. Meanwhile, don't forget, next month, I think it's October the 28th, is going to be the third webinar, which is going to be on trust in public health. Until then, thank you very much. Stay well, and let's get our great science out into the world. Thanks a lot. Bye-bye.
Thanks, everyone.
Thanks. Bye-bye.